Thank you. Thank you very much for introduction. I would like to thank Professor Mohamed Rella for inviting me. I appreciate that. So I will try to share my uterine transplantation knowledge. Experience across the globe and personal perspective. Well, I will touch our trial which we are having in Czech Republic, which is a two-arm. Then briefly, a lot what's been said already here, but I will go in a little bit more detail into post-op course, including rejection and infection, where we are having issues, and that was not addressed yet, including immunosuppression and some of the complications. Our trial, we started thinking of uterus transplant early 2012 when I went to see Mikael Olausson to Sweden, and I was lucky to attend some of the cases they've done. It took us 3 years to get the permission from Ministry of Health, and we got a permission for two-arm study, which is 10 living donor and 10 deceased donor transplants. The indication is OFI as usually, so that's been all touched and discussed. In our trial, the recipient must be having either husband or a long-term partner, and prior to the transplantation, 10 or more cryopreserved 5-day embryos to be ready for embryo transfer after transplant. It's a temporary transplant, so in our trial we leave the graft in for maximum either 2 pregnancies or 5 years with the graft, and then it should be removed and the immunosuppression stopped. And the main hypothesis of the trial is that the outcome from the deceased and living donors of the uterus transplant are equal. Patient recruitment indication, a lot's been said here. The infertility prevalence varies in papers. I think most important for us is the small subgroup of the untreatable infertility, which can be as high as 300 cases per million. So in Czech, which is a small country of 10 million inhabitants, we may have 3,000 potential recipients for uterus transplantation. So they have 3 options, again, that's been stated, either surrogacy or adoption or uterus transplantation. We published, and we wanted to see really what is the demand in Czech Republic. So so far we published 4 papers, where first of all, my gynec colleague, he's leading the largest unit in Prague, and they do vast majority of the Rokitansky surgery for the whole country. So we've sent a letter and questionnaire to 95 recipients from the past 10 years, asking first of all whether they've got stratified questionnaire, whether they've got sexual life and what sort of, and we published that, and that's probably the first paper on sexual life on women with Rokitansky syndrome in sexual medicine, and that was interesting because we found that vast majority of them have got normal sexual life after the neovagina creation. At the same time, we asked them whether they would like to have uterus transplantation, and then we were surprised again. Only half of them said yes. The other half said, well, we've got our life sorted differently, we don't want our own children, and the other half said yes. So if the potential is 300 per million, it could be just that half of those women may wish to have a uterus transplantation. And then we went through ethics and some of the assessment issue in the other 2 papers. The technical stuff's been described before in the previous talk. Some of the things we do differently, so I will just try to touch that. In our trial, deceased donor is aged between 18 and 60, no history of malignancy, 3 deliveries, 1 cesarean out of those 3. We do vaginal deceased donor. We do vaginal ultrasound, transabdominal ultrasound on the day of the retrieval, and we do also cytology on the day of retrieval, which was difficult because to get the pathologists which will tell you on the day of retrieval the cervix cytology was not easy to set up. We do detailed dissection of the uterus the same way as in the living donation. and we do the in situ perfusion because the flow goes very slow, and so we keep it going, and even when we start removing abdominal and thoracic organs, I clamp the aorta and we keep going with the perfusion, and on top of that we add the ex vivo perfusion on the bench, and then the uterus is nicely wide. I'm slightly worried of the precious perfusion, like using the syringe, because I think we may only open collaterals rather than perfusing the microcirculation of the graft, and we may end up with microthrombosis of the graft. So I'll really let it dribbling very slow, both living and donor and deceased donor retrieval, because it's just a very different organ for perfusion. We do hysteroscopy ex vivo to see whether there is not any issue inside the organ as well. So I'll show the pictures how we do it. So far, and we were lucky because we were permitted to do training retrievals, deceased donor retrievals. So we've done 5, and I think we've learned a lot, because our original idea was to cut everything out and do the work on the bench, including dissection and so on. We've tried, we failed. The anatomy is completely lost on the bench, so really the only way is to dissect in situ. At Ghent group had the same ideas. They asked me to come over, so I explained it to them. They amended the protocol because they were thinking of the same. And on top of that, we did 4 regular retrievals and deceased donor transplants. The living donor, the age, we've got the same limit, precise gynae assessment, including cytology, same for deliveries. We do CT angiogram, which is actually of little use. The arteries we can see nicely. The venous outflow is very difficult to assess, and it's not as nice as like on the kidney side or even liver side. I know Dallas does MRIs, which seem to be slightly better, but I'm still worried that the anatomy, especially the venous outflow, we can only assess during the retrieval, not before that. And so that's why all the recipients, we all tell that they may not end up with the transplantation if we are not happy with the graft. And it happened already to us twice. One was live donor and one was deceased donor, where we were not happy with the venous outflow and we abandoned the transplant. A big question is ovaries, and that's related to the venous outflow. If you wish to have nice ovarian veins, you have to go above the ovaries, and that's good for transplant. But in a live donor setting, then you may struggle if the recipient, if the donor is not postmenopausal, you may harm. And there's a big topic for debate whether if we do so and remove ovaries with a wish to do a successful transplant, whether the hormonal replacement would potentially harm the donor or not. No one even opened this discussion yet. It's true it's not life-saving organ, but I was told by going through the permissions at Ministry of Health, I was told by one of the ministers, they said, hold on, it is life-saving organ, because Europe is not dying from anything else rather than not having enough children. There is short hospital stay for the live donor, usually 2 days after surgery. It's like a kidney donor. The donor is walking around walking on the ward and ready to go home, and there is fast recovery going back to work. Deceased donor transplant workup, then the donor is placed on the deceased donor waiting list. Same rules as for the kidney transplant, so based on blood group and tissue type. So if there's more recipients in the same blood group, we decide based on tissue type, nothing else, not like the weight on the liver or so. Ideally, the retrieval on site, so in Czech we are lucky, we can move the donor to our hospital and do the retrieval in our theater, which is a big benefit, and we know that. We do cross-match, CDC, of course, on the day, and then fax and Luminex for the later on assessment. One may argue whether it does make a sense to do a cross-match in uterus transplant, because the recipients are not sensitized at all, and we have never seen one positive cross-match, so it could be that it's just a waste of time, but we do it because it is in our protocol, and one of the outcomes from our trial could be that it is not necessary to do the cross-match and you can proceed with the transplantation straight away. We do ultrasound, as I've said, CT angiogram. We do even on the deceased donors, because if we do split liver, which in these cases we do in basically all of them, we do the CT volumetry and the angiogram of the liver. So we just add the pelvis on top of that, trying to see or to get more information from the pelvis. Cytology, I mentioned that. And we transplant only if the perfusion is nice and homogenic, and if the cross-match is negative and the cytology is negative. It's open procedure, and 2 surgeons and 1 gynecologist attend the surgery. The living donor transplant is more or less the same, but the only difference is the ex vivo perfusion, which is slowish, far slower than kidney or liver or any other organ, sometimes just dribbling, and we just let it go slow, because then the microvasculature opens and the organ becomes nicely white, and I think that's the way of perfusing the uterus. Deceased donor retrieval, the dissection we start as like in Dallas, the first, well, we are the one and only team retrieving everything, but we start with the uterus. It takes about 2 hours to dissect everything, meaning there is no small branches left in the pelvis. There are just 2 uterine arteries coming off the internal iliac, 2 veins, and the ovarian veins as well. We do remove both ovaries from the deceased donors and keep the whole length of the ovarian veins. I'll show the pictures of the vessels in a second. And then we dissect, we cannulate both external iliac arteries, and that way we flush the graft. And then we dissect all the other organs, including split liver, and then we proceed with the retrieval. On the bench, there's a lot of work to be done. We will have to assess the quality of the graft. We do hysteroscopy ex vivo. We look at the vessels. We do not try to cannulate the vessels. They are very tiny, very narrow, and just the flow tells you whether they are patent and big enough, because if you try to squeeze the cannula in, you probably just harm the intima of the artery. We flush not with UW like Dallas. We use HTK because it's less viscose, and I feel it probably gives us a little bit quicker and a little bit more smooth perfusion than UW. And we preserve all 6 vessels, so both arteries, both uterine and both ovarian veins, and if they are good and patent, we do all 6 anastomosis. Couple of pictures. So dissecting the uterus very gently, trying not to pull the vessels. They are tiny, and even if we stretch them, I think we probably harm a lot, and then that could be one of the reasons for thrombosis. So we stretch very gently, holding the ligaments, back table ready here. Then we place the graft, which has been already flushed in situ, into the bowl, and flush again with another liter of HTK. And you can see that I'm holding the internal iliac artery in my hand, which is included in the graft. So then the graft looks like that. One of and this is a split liver, end of the classical split within the same case. This is one of the quality assessment, that the body of the uterus should be really wide and nicely flushed. If it is not, I think there's microthrombosis, and the graft should not be transplanted. This is another look, that the cervix should be completely white and nice, and again, that gives you the quality of the perfusion, I think. This is the graft with all 6 vessels, so 2 arteries you can see with the part of the internal iliac, and 4 veins, both uterine and ovarian veins. Again, the body nicely white, cervix. This is the ring of the vagina, and also you can see the here is a stump of the ureter left with the graft, because in live donor setting you have to dissect the vessels all the way along to the uterus. In a deceased donor setting you don't have to, so we basically leave a small stump of the ureter between the artery and the vein. The vaginal ring, one of the big questions is how long to leave it. In the Rokitansky syndrome, we need it quite long because the neovagina is short and narrow, and we had to adopt the discrepancy in size. But the longer you leave it, the higher chance you have got for vaginal stenosis. This is the hysteroscopy ex vivo on the bench, where the gynecologist can nicely play with the whole uterus and squeeze in the hysteroscope and really to assess the quality of graft in a very detail. And again, look at the graft, and then it's packed like a kidney, same way before the transplant. The transplant, some we do with a microscope if the vessels are small. We use microscope routinely. I do all the live donor kidney transplants with a microscope because it's very smooth and nice procedure. From 5 centimeter incision, you squeeze the kidney in, and then deep down you do your anastomosis. But of course you can do it with loupes, probably the same way. It's just the habits. Lower midline incision, dissecting the vessels and the pelvis and the rudimental. This is the rudimental part of the uterus, which needs to be cut in 2 pieces to get to the top of the vagina. That's it, cut it in 2 pieces. You have to tell your radiologist that it is there, because then they do not know what is there on the sides of the graft, these 2 parts of the rudiment. Then the graft is anastomosed to all the vessels with the bulldogs before unclamping, just like that, and then unclamping and the reperfusion and nice lipping. There was discussion about the ligaments and how to keep the graft in a position. I do not believe in the ligaments. I went back in 2 cases, and they did not heal even, although we stitched them with a Vicroid to the wall, abdominal wall. So the only thing, in my view, which is holding the graft in a position is peritoneal flap, which we take from both live and diseased donors and stitch to the bladder just behind the pubic bone, and that's holding the graft in accurate position. Another picture of the graft like that, fixed with the peritoneum, and just here is one-sided anastomosis. Behind there is the other side, and this is the way it looks after that. So there is midline incision. This is the Doppler probe, which we put around one of the uterine arteries, and here is the drain. The post-op care and the post-op course is quite difficult. It's the only organ which does not give you any lab function, so you can't measure anything, it's just there. And you can see it with the ultrasound, but the problem is sometimes you can't even see it with the ultrasound. So it's small, it's tiny, it's there, and you are worried of perfusion. So first of all we trained asked our gynecology ultrasonographists to look at the vessels for 6 months in all the patients in clinic to get a habit of seeing the uterine vessels in the ultrasound, both transabdominal and transvaginal. And same, I asked one of my angiologists who do all the angiology assessment for vascular and transplant patients. She did the same. So now I've got 2 different experts to see the vasculature after transplantation, which is good. On top of that, you get this Doppler. At the same time, we now think of changing to looking at the cervix, the viability of the cervix, like 24 hours or 48 hours after transplantation, because we didn't do it until now. Recipients stay in ICU for 2 days, on the ward for 5 days. We do regular cervix biopsies, one on the day of the first one on the day of discharge, which is day 7. We give immunosuppression, thymoglobulin induction, and then triple therapy with early steroid withdrawal in 3 weeks' time, and MMF stop in 6 months' time. That's our protocol. But now we've added azathioprine to some of the patients because they were running mild rejections even a year after transplantation, and we felt like monotherapy of tacrolimus is no good enough for transplant, uterus transplant long term. This is the ultrasound, so the picture of the uterus on the ultrasound. Here are already the vessels. Again, that's different to all the other organs. In many cases, you can see one side very nice, the other side not at all or very little, and the vasculature opens in about 2 to 3 weeks, and then you can nicely see both sides. So this is not happening with kidney or liver. You can see it from the beginning nicely, and it's not changing over the time. Another picture with the curves, another picture with the venous outflow and the curves. This is the way it looks in the outpatient clinic 10 days after the transplantation. This is the cervix for the biopsy, which we take just based on the protocol. You shouldn't really bite the same place again and again, because the pathologist will just tell you, I'm seeing just the scar, nothing else. So, or not enough to tell you whether there is no rejection. This is the scale of rejection. We've seen all the changes. So there's, on left-hand side, there is no rejection. These are our pictures from our patients. The mid picture is borderline changes. Right picture is mild rejection. We don't treat borderline changes. Sometimes we add a high level of tacrolimus. Mild rejection we treat with a shot of steroids. This is one of the complications, and that's vaginal anastomosis narrowing. We've seen that already in a couple of patients, and it's difficult to treat. So what we started to use is stenting. This is metallic coated stent, which is designed originally for esophageal cancer stenting, but can be used in this setup. You can see how it's nicely placed here, and it's because it has got shape memory. It slowly opens the anastomosis, and there is no need for any cut or any other intervention to open up, and you have got nice, even through the stent, you have got nice access to the cervix for the biopsies. And because we routinely stent bile ducts, in many cases we stent ureters, we probably should stent vagina, but that's just proposal. You may disagree with me. This is one of the interesting cases where it was deceased on a transplant. The lady suffered from herpes simplex infection early after transplantation, and even lost some of the surface of the cervix, which basically went off. And then it has overgrown again. She was doing well, and but she was not having menstruation. So we felt after some months we should give her stimulation to see the endometrium growing, and because there were no other issues, the graft was well perfused. We gave her hormonal stimulation, but there was no growth of the endometrium. Here was meant to be endometrium, but there was none. This is another picture of the same. You would guess there was meant to be endometrium, but there was none. So, because she was not growing any endometrium, although she was already on maximum stimulation, we decided to remove the graft, because we felt like there won't be any successful transfer at pregnancy after that. And at the same time, we prepared her for retransplantation, because we had altruistic donor. And there were quite few lessons we've learned from that case. First of all, the live donor had really bad veins, although we didn't see that on the CT. So we canceled the transplant and sent it off to pathology, and we were surprised that she's had high-grade dysplasia on the cervix, although she'd had a couple of negative smear tests before. So that's one of the things we've learned. The negative smear test does not mean there is no risk of transplanting potential malignancy. And then we had a very tough discussion about vaccination of this recipient's population, and we can talk about that. And at the same time, because we removed this graft, we were surprised because we have documented the first ever chronic rejection. This lady lost her graft, or basically the endometrium, because of chronic rejection. although she's been running good tacrolimus levels, and we did not see any signs of rejection in the biopsies. But it could be that it was affected because she's lost the surface of the cervix initially because of the herpes simplex infection. This is severe rejection, another interesting case. We had one, and she's now having embryo transfers, but we were really worried because we faced really, really bad severe rejection. And when I saw this picture, and the pathologist just said, well, this is severe rejection. If you look in more detail there, or into more pictures, there are immature lymphocytes and even aggregated lymphoblasts. And then we looked at the lab, and I said, well, and isn't this PTLD? And it was 6 months after transplantation, very typical time for PTLD, so lymphoproliferation. So then we had a very detailed discussion with the pathologist, and he said, yes, you might be right. It could be either severe rejection or PTLD. So we've added, here is clear an immature lymphocytes and lymphoblasts in groups. So we did CD3 and CD20 stain, which has sort of pushed us towards the rejection rather than PTLD, and there was one and only choice, either removing the graft or give ATG. So I decided to give ATG. Unfortunately, we were right with the diagnosis of severe rejection, so that one healed, and she's now has no rejection. We added azathioprine, and she's ready for the first embryo transfer. So there's issues. We have got permission for 20. We did 9 uterine transplants, 4 DBD and 5 live donor. 2 grafts we removed from thrombosis. One actually it was like in Sweden, case 2 and case 8. So the message is don't do cases number 2 and 8. Both thrombosed early, not really early. The one day 7. The first one, where was good perfusion on the graft and the Cook Doppler. And day 7, she was for biopsy in the morning, and there was no sound. And 6 p.m. before that, she had scans, and everything was fine. Something happened overnight because in the morning there was silence, and the graft was completely thrombosed. Day 7, we went through all the cross matches again, trying to find the reason for that. We did not find any. And the second graft loss was even longer after that. Basically, she had 4 veins. We anastomosed only 2, and she thrombosed venous outflow on day 5. So what we managed to do is we went back, we opened the other 2 veins, anastomosed them as well, and declotted the 2 clotted veins. And she was having good flow throughout the graft for 3 weeks. And then she again one day clotted off the graft completely 3 weeks after transplantation. Again, we went through the immunology and everything, trying to find the cause for that. We didn't find any. But one of the things we found is that some of the recipients bleed in theater and day after. And that's probably thanks to thymoglobulin induction. So we started to doing routinely ROTEM in theater, and we realized they've lost fibrinogen. So we do adjust clotting in theater before we close the abdomen, trying to make sure there is no clotting issues, because then they probably develop clot around the vessels, and that could be one of the other very technical cause of thrombosis, but could be one of the reasons. We had 4 vaginal stenosis which we have stented. One of the first one, actually, my gynecology colleague tried to cut these anastomosis. He tried 3 times, and then he caused a vesicovaginal fistula. So he said that we should remove the graft. So I said, no way. Took the patient back to theater, and fortunately I managed to sort of cut the vaginal anastomosis, re-anastomose that, and I opened the bladder behind the bone, and from inside I stitched the fistula, and she's healed, and she's had already one unsuccessful embryo transfer and waiting for second one. So again, bad complication, but we keep learning. 4 patients had leukopenia. because of the immunosuppression, but herpes simplex infection as well. So it could, one may argue it's signs of ovarian immunosuppression. So we've treated that. We've done not 53 or more biopsies now, one severe, one moderate, and quite few mild, but very many borderline changes. So now we are trying to do the three-way blind trial with Sweden and Dallas, so that the pathologists will read blindly the findings from the other unit, trying to see where we are with the borderline changes versus normal findings. The worldwide experience, I think this is the most important table for today. So far there were, as far as, if I'm right, 38 cases done in the world. First Saudi, second Turkey, then the 9 cases Swedish group, then 1 case in China, unknown results, 1 in Cleveland where the graft was removed, that was deceased donor, and then we started in April 2016, we did our first 3 cases, then Dallas started September or later on 2016, did there 4, and so on. So far this is the worldwide experience with uterus transplantation. I think more interesting is if you look at this is deceased versus live donor. So Gothenburg is 11 live donor only. We are the second or group number 2, where we have done 4 deceased and 5 live donor cases. Third is Dallas with 2 deceased and 6 live donor cases. And I think these are the 3, let's not call them big groups, but the other centers did either 2 or 1 transplant, where only Sao Paulo did 2 deceased, and then Cleveland and Antalya did deceased, or the other groups go the live donor way. This is grafts removed for thrombosis. I think this is important message. We all fail and we all get thrombosis. So Gothenburg got removed 2, but 1 was not microthrombosis, it was infection, the other one, I think. We removed 2 grafts from thrombosis as well. Dallas, as it's been presented, 4 out of 8 cases had early graft failure and removal, and you see that 4 is Sao Paulo, again 1 out of 2 is out. The 2 Indian cases, we just had discussion about that. In Gothenburg they were verbally presented as failed, but there is no data published on that. Same the China cases, no one really much knows about that. And this is the number of grafts sort of ready for IVF, so I'm counting just the new group, Michael, so we've done another 2, so those are ready. We have got in Prague 6 patients now having their embryo transfers, and Dallas has got 3 if I'm right, and then there are another 5 cases worldwide potentially, but we don't know much about that. So the perspective, the deceased donor retrieval is technically demanding and I think more difficult than expected. Graft is resistant to the preservation injury. That's another trial we've done. We looked at the preservation injury every 6 hours, and we found on these our training retrievals, and we found out that after 24 hours the first ischemic damage starts. Before that there is hardly any. Hysteroscopy and cytology is important in the deceased donor setting. The live donor hysterectomy is long procedure but safe to the donors, or seems to be safe. All our donors except 1 had BMI of over 30 and it was not an issue, so it's probably acceptable, except the general risk of surgery. A CT angiogram is of little use comparing to kidney or any other organs, and cesarean section. One of our donors had even twins from cesarean section, and it was basically not a big issue. There's not usually many adhesions around the uterus. It's smallest organ that we've ever transplanted, I think, with very tiny vessels, We use microscope. Ideally, we anastomose all 6 vessels. The anastomosis, the vaginal anastomosis is quite deep, and especially in the inherited absence cases, and it could narrow in some cases, as we've shown. There is no function to be measured after transplant, and the regular ultrasound Doppler and cervix biopsies is needed. The immunosuppression we discussed. And this is so, is it gonna, the personal perspective, it could become one day in our hands, small volume program if you want. So these are our Prgue figures. So there are some small programs. Of course, the kidney and liver is big, pancreas as well, but pancreas only, lung, hearts, islets, or small bowel in our hands is a small figures, and that's why we can probably face it for the next couple of years, but we will see. There's still a lot to be proven. The demand, we keep talking about that, but we don't know where we are exactly. The indications, especially the group of potential recipients with so-called non-functioning uterus, I do not think this has been defined, and that's for our gynecology colleagues to define this group of potential recipient. What does that mean if a patient has got non-functioning uterus? When to say that the patient is for a transplant if the IVF fails, for after how long time of how many tries, that's for you guys. For live donor and recipient, it seems to be safety surgery. There's virology issues, including herpes simplex and HPV. There should be debate about vaccination, when and whom. The immunosuppression, there are some side effects. We also measure, we do filtration of on all our recipients on regular basis to see at the end of the trial, and even graft removal and stop of the immunosuppression, whether we did harm the renal function or not. Because what we can see, and the Swedish group has proven that as well, there is a decline in renal function once you put those patients on the immunosuppression. So we have to prove whether we do not harm. Rejection, acute and first our case of chronic rejection, when to do the biopsy and how to do the biopsy. It seems to be straightforward, the cervix, but it looks as it's not going to be for everyone. The IVF pregnancy and risks and safety, there's another group of topics to be discussed in more detail. When to remove the graft and what are the reasons. We did remove one for not growing endometrium. That's again the first ever removed graft for this reason, and we can of course touch that in more detail. There should be question of retransplantation. These patients have got frozen embryos and they wish to have their own children, so there must be debate on retransplant and ethics. This is our group of colleagues who keep an interest on uterus transplant, and that's it. Thank you.
Padma Priya to felicitate Dr. Jiri Fronek.
Thank you very much for excellent presentation. I am pretty sure in future many people will need what you showed to prevent stenosis, this device. I would like to know what is this device, it is biodegradable, what is special, and which company makes it and where it is available?
The stent is a non-absorbable metallic silicon coated stent. We haven't used it yet as prevention of stenosis. We only use it for treatment of stenosis. But now we are discussing with the team whether we shouldn't, like after the first biopsy, place the stent into the anastomosis to prevent the stenosis, but place it temporary. All the stent we have placed in, we already removed, and it just opened up the anastomosis and did the job. So it's a temporary placement of this stent for between 2 weeks and 2 months is the time of the placement.
Why you chose this stent?
Because this is the only size which allows you on the market, which is officially on the market with the CE certificate in Europe, which gives you enough access to the cervix for the biopsy. There is no larger stent.
Where it is used?
for esophageal narrowing after either for esophageal either tumors.
Which company markets it?
I can't remember. I can
Thank you so much.
email
Thank
you the details.
Okay, thank you.
But it's one of the issues with the stent, it's off-label indication. So we had to go through the ethics committee to allow us to use it. But they said because our trial is covered by the Ministry of Health and that's for to prove sort of unproven methods. So it's above it's above the use of label stent, and they allowed us to use it. But officially, of course, you shouldn't use it for anything else rather than esophageal stenosis.
Thank you.
How early can you identify that the woman is rejecting the graft?
Sorry, say again.
How early can you identify that the woman is rejecting the graft?
We do the first biopsy on day 7. We didn't see rejection. In these early biopsies, we didn't see the rejection yet. So if they were rejecting, it was usually 2, 3, 4 weeks earliest after the transplantation.
Will she have any symptoms of it? Or
No, not at all.
Not at all. It is only the biopsy which is going to confirm.
Yes.
But then how long does she take to menstruate?
All our donors started menstruation 6+ weeks after the transplant, including the recipients who had a transplant from postmenopausal donors. We did not stimulate the living postmenopausal donors before the donation, and we did not stimulate one single recipient except the lady with the lost endometrium and chronic rejection.
Okay. Then when is she really ready for an IVF? Any time gap is required for the IVF procedure and the transplant?
You mean how
yeah,
quickly?
what is a gap? Like after the transplant, after how many months or years she can...
Well, in our protocol, we have got 6 months MMF, which is a toxic drug. So after the MMF withdrawal, we double check the acid level, make sure the drug is gone from the blood, and then after that they can go for embryo transfer. But we did not start with transfers in our cases earlier than a year after transplantation. It's in our protocol. That was the intention. I know Dallas started earlier.
So all these women will only have a cesarean section because there are no innovations. She can't get into labor.
No, only cesarean
Only cesarean
section.
sections.